The patient is a 38-year-old lawyer in his own busy law practice. He is a heavy smoker who smokes 1 to 2 packets of cigarettes a day. Otherwise, his medical history is clear. The patient has moderate dental anxiety and only prefers to see the dentist when in pain. He came to my practice with a chief concern of a lower right second premolar restored 4 years ago, but not fully satisfied with the appearance and comfort of the restoration. This was done from another practice. There was an occasional sensitivity to cold fluids, but was extremely painful suddenly 2 days ago, with severe throbbing pain which is elevated by heat. On examination, the patient has a skeletal class 1 with normal third facial height. There's good range of movements with no pains, clicks or crepitus from the temporomandibular joints. Patient has a satisfactory oral hygiene but seldom flosses. When recorded, he had a basic periodontal examination score of 2. The tooth in question was heavily restored, and the diagnosis that we obtained was caries and irreversible pulpitis of the premolar of the 4-5. Discussion of treatment options are as listed in the write-up. The definitive comprehensive treatment plan would include endodontic treatment of the 4-5 and then followed by a post and crown. Our main aim is to remove the symptoms of the disease, where in the first visit an emergency dressing of ladder mix was placed in. 2 weeks later, rubber dam isolation is used, where the working distance with a periapical and an apex locator is used. Mechanical chemical preparation involves irrigation with sodium hypochlorite and EDTA gel. Medicaments that were placed in between visits was calcium hydroxide and ladder mix mixture 50-50, and eventually, in the third visit, a full calcium hydroxide dressing. Coronal preparation was made with X-Tot ultrasonic tips. An apical preparation to the working distance was made with Pro Taper and rotary files down to master apical file size 30 to the length of 20.5 millimeters. Hand files of a smaller size are used in between the change of rotary files and irrigation to reduce the risk of file transportation and zipping. As mentioned earlier, full calcium hydroxide dressing is used with the final provisional restoration prior to the next stage, which is the obturation of the root canal of the 4-5. The occlusion is checked and made sure that it is not too high on biting in between the visits. Obturation material of choice would be mustard gutta percha point, size 30, and Endorest sealant. The sealant has an affinity for moisture deep into dentinal tubules and lateral canals, which provide an adequate and satisfactory seal. The material is methacrylate based and relies on chemistry rather than heat or pressure to fill in the canal. Therefore, this choice would reduce the risk of additional root trauma or fracture. It is a self-priming resin sealer, which is more effective in obturation in less time. It has the same radiopacity as gutta percha and bonds to resin-based core composite materials. It is retreated if combined with gutta percha. It's biocompatible, and it provides syringe delivery to the apex of the root. The master GP point is then disinfected with sodium hypochlorite and dried by a dry, sterile gauze. paper points were used to dry the canal apex, and the custom navigational tip syringe that is filled with the sealant, where its tip is then inserted 2 to 4 millimeters short of the apex. The sealant is expressed while withdrawing until the sealant is seen at the top of the canal. To avoid bubbles, the end of the tip is constantly kept buried while withdrawing slowly from the apex as the canal is being filled. The master GP is then inserted and a passive apical tightness is felt. The sealant is left to set around 20 to 30 minutes and the extra unwanted gutta percha is then seared off. The tooth is then been provisionalized with a layer of cavet, some glass ionomer cement, and some flowable resin on the occlusal sides. The occlusion is then been adjusted so that the bite is comfortable. The tooth is then left for a few weeks to a month, and it has been symptom-free since then. The tooth is then been ready and prepped for a crown preparation in the next process.